who are gathered here today. Thank you for making time and for being in the session today. So I want to be very specifically talking about sexual dysfunctions in pregnancy. And concerning infertility is obviously associated with pregnancy, and the sexual dysfunctions become a very important aspect in how it is centered around pregnancy and fertility itself, because the way that these cases are presenting to us and how we are able to understand these things are very interesting. And I would like to start off with some basic understanding of how hormonal changes and sex drive during pregnancy, as we are understanding, can affect the drive itself and thereby cause a lot of issues, such as elevated levels of estrogen and progesterones, as we know, are very vital for sustaining pregnancy. So the levels are quite high. And these hormones influence blood flow to pelvic organs, contributing to an increased sensitivity. So this, in fact, can go either ways, can also improve, in specific cases, improve our libido or alter the libido and increase libido because of increased genital arousals. And sometimes due to hypersensitivity, this can also cause. So we need to understand both aspects of it. Whenever these hormones are influencing the blood flows to these organs, it can go either ways depending on the person, how their system is reacting. So in the first trimester, we see an increased HCG surge, and then therefore this hormone also causes a lot of changes that adds to nausea and fatigue. So these symptoms, though are very general, are very important in how it can alter our sex drive. So there may be an impacting on the sex drive. So this again is very individualistic. So there can be low sex drive, initial challenges in pregnancies, accepting that pregnancy has happened, hormonal changes that happens with pregnancy. All of these things cohesively causes changes in the way that the woman can feel during the first trimester. Estrogen, as we know, peaks during second trimester, again promoting more genital blood flows and heightened arousals. So, and also it's a great time to have sexual intercourses. Is the second trimester where it's the implantation has taken place. All the other aspects of the first trimester, nausea, fatigue, etc., settle down. So it's also a safe space to be, even for challenging pregnancy. Sometimes it's a safe space to understand. And of course, after discussing with your treating physicians, I think they can have that sexual intimacy going on. Many women experience increased libido and sexual satisfaction during this period. So it's very important to highlight these things. Mainly, a lot of them are riddled with fear. Are we allowed to have sex during pregnancy, etc.? As we know from our patients, I think it's important to educate our patients on these lines. So I'm just trying to highlight each trimester accordingly. So breastfeeding also stimulates prolactin, so suppressing estrogen and impacting libido. So this is around the post-pregnancy period, around the initial aspects of the breastfeeding periods. The prolactin increase can suppress estrogen and impacting libido in a big way. Oxytocin, of course, released during pregnancy and intimacy, fosters more emotional bonding. This also means that if the partner is more reciprocative, also shares responsibilities and things like that, and is available for the for the partner emotionally and physically. So along with the oxytocin increases, these psychosocial changes also causes improvement in the way that they have bonding during the post-pregnancy period. Hormonal responses vary widely among individuals. We have to consider that. Emotional and psychological factors hugely contribute to the experience of sexual. So what are some of the behavioral aspects impacting sexual wellness during pregnancies? There are a lot of them. Hormone fluctuations is one side, but behavioral dynamics significantly influence sexual well-being. Psychosocial factors play a great role. So what are some of the psychosocial factors? It could be starting with the general stress that the patient is going through, or the living conditions that the patient is experiencing. Dynamics in the interpersonal aspects between the couple can be hugely a factor. Extended family and their influences, and the living arrangements. I cannot stress enough, but the living arrangements in which the couple are staying hugely also influence that. And before the pregnancy, also how the interpersonal relationship was will be an important factor to understand, and how their sex life was is a very important aspect to understand how their sex life will be post-pregnancy or during pregnancy, and their intimate lives will be predetermined by a lot of these factors. So we should always and always assess, apart from the hormones and the blood flow that we are talking about. So we have to clearly understand that there is a huge impact on psychosocial factors. It can be evaluated just by asking a few simple questions like, how are things, how's the partner doing, how how much of responsibility sharing is happening. So maybe around maximum 5 to 6 questions, including the support system that the women may have during the post-pregnancy or during the pregnancy period, can give us an idea and open up the discussions for a better sex life. And promoting the sex life can come through initiating talks like this. So as we understand, chronic stress that can be because of any other reasons also elevate cortisol levels, affecting reproductive hormones. So anxiety may contribute to physical symptoms that impact sexual desires. For example, there could be a lot of panic sensations, activation of sympathetic activities in the central nervous system, can have dryness of mouth, drying around the mucosal areas, causing impact in the way that the sexual libido is experienced as well. Lack of lubrication is also something that women experience during the anxiety periods. Of course, breathing difficulties, panic attacks, IBS, different physical aches and pains, joint aches, musculoskeletal systems are all sometimes the manifestation of anxiety. So it is important to understand that delineating or clearly dissecting how much of these things are physical, how much of these things are general medical conditions. It could be iron deficiencies, hemoglobin, or other hormonal changes like thyroid, pre-diabetic or diabetic status. It could be hypertension. So the main drive away or the takeaway point that I'm trying to drive across is that managing anxiety is important, but before that, we got to rule out so many other medical conditions that we just spoke about. So, but anxiety also mimics that. So, whenever we are not able to identify that from a physical cause, we need to ask these psychosocial factors, chronic stress levels that may be contributing. Anxiety being manifesting in the form of a physical symptom is very important to understand in the context of pregnancy, especially. So, it also causes a lot of change in a woman's body, right? So it is very important about how sexual libido arouses and initiating or involving themselves in sexual activities has got a lot to do with how we feel about ourselves. Our self-image, our self-confidence, and self-worth are greatly attached to how we feel and how we can engage with our partners in sexual intimacy. So during pregnancy, because of the hormonal changes, because of that, it causes a lot of mental health disturbances, and so it causes a lot of hormonal changes, and also it causes body image concerns. Increased weight gain, altered physique may affect self-esteem very, very deeply, and it can be something which is not discussed a lot, and sometimes the women may not even be speaking about it because it's normalized. It says, okay, everybody goes through these changes, it's normal, so there's nothing much to talk about. So but they don't talk about their feelings much, and then this disturbances that they may feel that they're not so attractive, so they may fail to initiate sexual activities. So this can be very confusing if communication is not a very key element in couples. So body image concerns are to be addressed, are to be understood, because if someone is not very comfortable with the way they feel because of the pregnancy related aspects, it calls for a discussion. So relationship dynamics is exclusively mentioned here because partner support is very, very important again. So partner's involvement can mitigate stress. It can enhance emotional connection. So whenever there is a partner involvement, the woman in the relationship may feel less stressed, and then it can enhance the emotional connection. And as we all understand from the Besson's model, the physical intimacy or the sexual intimacy or the seeking out or being receptive to sexual behaviors will require some amount of emotional connections, and this can be enhanced through various other means. It's important to discuss with the male partners about what they can do to improve this kind of a connection, which can ultimately help them to have a better sexual engagement with each other. So hence I was talking about open communication to foster mutual understanding. So effective communication about sexual needs and desires. We see that the minute that the pregnancy happens, the couple stop talking about sexual activity itself. We've seen that a lot because their entire focus shifts from considering sex as an enjoyable, desirable, pleasurable sexual activity or an intimate act to taking care of the baby, running around with reports, going to the doctors, managing the finances, taking care of other household activities, extremely thinking of pregnancy as a very important activity. And then, the fears are immense in terms of, I think it can harm the baby, it reproduce again. A lot of myths surrounding pregnancy and sex during pregnancy are to be effectively communicated between the couple and also between the doctor and the patient, which can help them to in turn have dialogues around their sexual needs and desires. It is important to prioritize this because we have also seen that during the pregnancy, when couple don't emphasize on or prioritize their sexual needs and desires, they have a very long gap because the entire pregnancy can last, as we know, about 9 months. And then after that, there's a lot of caretaking of the baby, a lot of sleep wake cycle disturbances, stress that is associated in the living conditions, social arrangements and engagements. So breastfeeding also causes a lot of difficulties. And apart from that, any other medical conditions can only add to the burden. Sex definitely takes a backseat. So hence, improving or prioritizing their sexual needs and desires and effectively communicating during the course of pregnancy can be a very great way to avoid the sexual dysfunctions that we can see post-pregnancy, which couples come up. Because masturbation also becomes a very important aspect where if at all there's no sexual activity happening between the couple, the male partner can be involved in masturbation predominantly, and then that becomes an easy go-to route, and then the ratio changes, and this affects the way that the couple can bond post-pregnancy. So please also address concerns and fears through open and non-judgmental dialogues. The fear of being judged is super high in anybody having these sexual issues, and during pregnancy, they may not even want to talk to the doctors because they feel like the pregnancy is done. The doctor may misinterpret, or they may have this kind of a false understanding about how we doctors feel about sexual activity. So having an open-minded, non-judgmental dialogue again and asking questions, one or two questions around these lines can help them understand that it's an open forum, it's an open discussion that they can have with the doctors. So the cultural and society norms heavily influence, especially in joint families. It has a very important role to play, and especially also in families where the parents have a very strong hold. Nonetheless, despite being 30s or late 20s or 30s or early 30s, when a couple of them get pregnant, we see that as a part of our socio-cultural aspects, that the familial control and influence. Obviously, it is meant in a lot of families to be good, and we can call it as overprotecting their kids, etc., and having heavy influence on everything that they're trying to do around pregnancy and whatnot can influence how the couple can feel during the pregnancy as well. So it's important to identify the relationship dynamics. So encouraging the couples to explore and redefining their own values is important. They need to understand that, yes, we are connected as a family, but it's important to draw boundaries in this situation so that they feel that sense of self is protected, and that can further enhance the couple bonding while they're also attached to the family. But they need to have this clarity between themselves, and then they can in this process, which is also helpful once the child comes in, right? So it is helpful for them to redefine their own values and expectations. So these are some of the relationship dynamic factors that we have to discuss. So we can also help them by providing resource on pregnancy related changes to manage expectations. We can also help them with education materials, which can normalize experiences and reduce anxieties. We have to talk about myths that sexual activity and pregnancy can bring us. So very simple things, but very important things to be addressed. We should not forget this during our discussion with our patients, and helping people with accurate information can alleviate a lot of concerns. So that was the general aspect of pregnancy as a couple, but I also want to specifically focus what I see on a very, very regular basis in our clinics here in Bangalore, in Passion Fruit. We see a lot of ovulation specific anxiety. So now this is under-recognized in a lot of cases because the anxiety, number one, what we're talking about is it can come as thoughts, it can come as emotion, it can come as body symptoms, it can be also seen in behavior. The most important aspect is these are various manifestations of how the stress about pregnancy can present. And there are some specific behavioral patterns which are seen between the couples. So anybody who's trying to conceive can understand that when they start conceiving, they initially start thinking of it as a very natural process. They start on with it, but somebody specifically having some sexual dysfunctions even before they're trying to conceive. For example, a male having any premature ejaculations is super concerned about ejaculating even before penetration. So that causes and brings up a lot of fears around pregnancy, that how will we be able to do it, and what if I don't do that, what if this happens, etc. So also somebody with erectile issues or erectile dysfunction, difficulty to maintain arousal during the penetrative act, or difficulty to even penetrate, can have fears around how will the pregnancy happen. And women mostly with vaginismus. So they find it very difficult with the anticipatory anxiety that they may have to even allow penetration to happen. So unconsummated marriages, long gaps, difficulty in initiation of sexual activities, even before thinking about pregnancy, can only further complicate the matter of anxiety around ovulation. Even if they bypass all of these things, and if they haven't sought help from a proper professional, and if they haven't really worked on the issues, on the hormonal issues, the biological issues, the general medical issues that can be affecting and in turn presenting as sexual problems even before pregnancy. So all of these burden, if not addressed properly, can only exponentially worsen during the pregnancy. So specific behavioral patterns seen between the couples are: the male is stressed about their own performance related issues, the women is stressed about the social aspects, the family aspects, because everybody has their eye on the women in our Indian situation and even otherwise also. So whenever the fertility is not happening, it is very common for people to nudge, people to raise an eyebrow, people to ask in social settings about what's happening. You guys have been married for so long. When is the good news, etc. So this is very, very triggering for the couple who are facing these things. They don't express that. They kind of shy away from social gatherings. They don't want to meet a lot of people. So these are all the specific behavioral patterns that are like the undercurrent when people are not talking about it at all. And it's very deeply felt. And this adds to the burden and the trauma that the couples are experiencing. Anxiety about not conceiving is super huge, right? So what they do is they go all ballistic with the way that they want to achieve this pregnancy. So imagine a couple who are having all these issues and they don't have a sex life. Yes. So when they have all these things going on, they're super anxious about it and they haven't had a very great sex life. They may have consummated and they may have had sex life maybe a few times, and they've had a long gap, and now they have this huge pregnancy pressure building up. So they go all ballistic about it. They start focusing and they start trying to have sex only with an outcome based approach. So they know that the ovulation cycle is there. So day 10, 11, 12, 13, 14. So they just keep focusing only on these dates and not on all the other dates at all. So this causes a lot of negative behavioral cycle. So each menstrual cycle, when it happens, build anxiety. So the buildup is real. And the technology such as app trackers, like tracking your ovulation, tracking your temperature, tracking when we had last the sexual activity was, when we're supposed to have for a girl baby and a boy baby. There are tons of these things which are causing a lot of chaos again. So like I mentioned, outcome based approach is very, very detrimental because it activates a flight and fight mechanism, activates a sympathetic activity because of which the couple are not able to have good experiences. This leads to a lot of arousal problems. In males, it can lead to erectile dysfunctions. In women, it can lead to lack of lubrication, pain, vaginismus, etc. So it doesn't activate the required centers of the brain. Instead of a parasympathetic response, a sympathetic response because of the flight and fight, because of the entire mindset that is created because of all the things that we spoke about. So there's always a conflict between excitation circuits and inhibition circuits. Though there is a lot of sexual excitation from the way that we can look at it, couple during these times who are clearly focusing only on pregnancy, they want to cut short the foreplay. They say, foreplay we have done enough, or we don't want to do foreplay. Now is not the time. We want to focus on pregnancy. Such a wrong thing. So because the inhibition circuits gets activated because of all the thoughts and all the negative feelings and the previous failures that they were experienced. The other challenge is also the low testosterone, and how we all know that treating low testosterone and supplementing and the sperm count effects that it has can be quite challenging. So that's important to address. So there is a specific cycle that we see is happening. It's like an obsessive compulsive cycle. The first phase is repeated thoughts. There's a stress buildup, compulsive phase of checking, rechecking, reassuring each other, trying to always talk about the problem, trying to find solutions all the time. Because I see this a lot in a couple. They keep talking about the problem a lot, but that only builds and adds to their mental tension without really or without really providing a solution. So communication is great, but also solution-based approach and a mindset-based approach is required. And this becomes a constant loop, which we have to educate the couple when they come to us. Family pressures and cycle between the entire two families, the girl's family blaming the boy's family, and then all of these things add to the kind of pressure that the couples may face So the clinical considerations could be, in brief, like I mentioned, psychoeducating, including materials, do's and don'ts. Specific behavioral changes has to be mentioned, because along with pharmacotherapy, unless until the couple and the male and the female, partner involved in this relationship do not change their behavior, do not uncouple from these things. Without the behavioral change, just the pharmacotherapy, won't help. So it's an overall holistic approach, which we see works. So SSRIs can be used in male partners who are having these issues for anxiety, where ovulation anxiety is seen. PD5 inhibitors and nutraceuticals, as we are all aware, can be used. Lifestyle modifications is immensely important. Mindfulness can be a great tool. Relaxation trainings can be extremely important for helping the nervous system to be more relaxed. And participating more frequently and sensate focus techniques can be initiated again, where they stop looking at the ovulation cycles, when they stop having that outcome-based approach and trying to think and reinitiate the senses and keeping sex very basic, while they still are engaging in the desire and the pleasure pathways are activated rather than outcome-based and pregnancy-based approach. So breaking the anxiety cycle through behavioral modifications is a very important key factor. So I think that was the summary quickly that I wanted to take through. So I hope it was okay, it was clearly understandable, and thank you for your patience. Over to Dr. Nitish.
Thank you, Dr. Shivadev. Excellent content. So we'll just take the questions in the end. Right?